Hey guys, welcome to our lesson on non-traumatic musculoskeletal disorders. From the standpoint of emergency services, most musculoskeletal complaints are related to recent trauma. However, there are numerous non-traumatic conditions that involve the musculoskeletal system. And although these conditions are generally chronic, during acute exacerbation, the patient actually may summon EMS for emergency medical care. Now, many non-traumatic or medical musculoskeletal disorders are inflammatory or autoimmune in nature. Rheumatologists or physicians who specialize in the treatment of non-traumatic conditions that affect the muscles and joints and the bones oftentimes are going to care for these types of patients. We may also see physicians who specialize in physical medicine and rehabilitation, also manage many medical conditions associated with the musculoskeletal system. And so as we go through this lesson, we detail the majority of these conditions, several conditions of the musculoskeletal system that are non-traumatic. Even though these do not commonly prompt EMS runs, from time to time during your career, you'll probably be exposed or called upon to treat a patient who has one of these types of conditions. And so with that, let's jump right into it. As we talked about, most musculoskeletal complaints relate to a recent trauma. A lot of these non-traumatic or medical musculoskeletal disorders really focus on the two primary categories of inflammatory or autoimmune. We've talked about rheumatologists already and physical therapists or physicians who specialize in physical medicine and rehabilitation. Now, when we start to talk about these musculoskeletal non-traumatic disorders, most of these we're going to have to really focus on the pieces and parts of the human body. So we'll be reviewing some anatomy and physiology. With the musculoskeletal system, we know that we're talking about both muscles and the bones. We know that it provides the body with form, support, stability, and the ability to move about normally. Otherwise, we would just be a big bag of jelly-like skin. Kind of gross. Slimer from Ghostbusters always comes to mind. Now, the skeletal system is going to provide that structure in the forms of bones, joints, ligaments, and connective tissue. We also know that muscles and tendons and that connective tissue do play a large role in this, as they're known to break down in both those autoimmune and other musculoskeletal type of diseases. The other part we have to look at is not only the muscle system, but the nervous system, because we know it plays a major role, again, in those non-traumatic degenerative-like conditions. So let's talk about the skeletal system. The skeletal system has 206 bones, classified based on their shape. This is a review from your anatomy and or your EMT class. We know that they're classified based on long, short, flat, and irregular. With the skeletal system, long bones are found in the extremities, short bones are found in the wrist and in the ankles. Flat bones form the skull, ribs, and the sternum, and your irregular bones are going to be what are found in joints and throughout your spine. An example of irregular bones could be your vertebrae. A flat bone could be an example of your scapula. Long bone is your humerus. Another example of flat bones is going to be your ribs. The short bones you're typically dealing with have to do with the tarsals in your feet and in your hands. The other part that we have to recognize with long bones is, well, really, what's their basic anatomy? We know that we have the proximal epithelius, I can never say that, epiphysis, I believe is how it's pronounced, the diaphysis, and then the distal emphasis. Don't tie me to those being properly regurgitated, stated to you. Long story short, that's kind of what you're looking at. One of the things that's important here, though, is to recognize the difference between spongy bone and compact bone. You're going to find that spongy bone is very light, and it's going to be typically the area that if we're trying to access an IO site or something along those lines, it's going to be easy for us to be able to do. The compact bone is what we have to get through in order to get to the spongy bone. We also have the medullary or the medullary canal, which is where the bone marrow is going to be housed, and that is a yellow, fatty-like material. When we put in an IO, we're looking to get in through that compact bone into the spongy bone and into the medullary canal, where we can actually be able to aspirate and hopefully pick up some of that marrow to let us know we're in the right location. Now, bones are joined together by ligaments. So remember, ligaments join bone to bone, tendons join muscle to bone. We'll get into tendons in a little bit. So again, it's going to allow us to move. Depending on the joint, it's going to depend on the type of movement we have. Gliding joints, those are going to be things like your wrist and ankle. Hinge joints, obviously your knee and elbow. Saddle joints, believe it or not, the base of your thumb is considered to be a saddle joint. Your pivot joint is going to be an example of your forearms. Elliptical joints are going to be where you're like things in your wrists. Can give you a lot of direction there, and then same thing in your foot. And then ball and socket like your shoulder or your hip. And you can see there's a ton of these different types of components. There's an example of your thumb with the saddle, your shoulder with a ball and socket. You may be looking at an example of a pivot like you would see with your radius, your ulna, a hinge joint at your elbow, and then an epithelial joint where you're going to be kind of getting that multi-directional, almost like a joystick type, where you would see in your wrist and in your ankle. So one of the things we have to recognize with the skeletal system is that joints contain cartilage, right? And so that gives us flexible connective tissue that's going to provide support and structure for our joints as we move about. The avascular tissue is not supplied by blood vessels, as the name would ensue, right? A without vascular, referring to blood vessels. They are found outside of the joints in things like the ears, nose, larynx, trachea, and then in the rib cage as well. Now, as we look at the skeletal system, we also look at haline cartilage because this is what lines bones in joints. We also have elastic cartilage, which is going to be a lot more flexible, and it's found in the outer ear and in the larynx. A lot more flexible to allow for movement, especially things with vibrations where they're needed, like in the ear and in the throat. Fibrocartilage is the strongest and most rigid type of cartilage we can see. These are typically dealing with intervertebral discs of the spine that's going to, as far as helping create that structure to the vertebral column, along with connecting tendons and ligaments to bone. It's what allows for it to actually adhere to the bone. Now, the other part that we typically are going to see here with the skeletal system is that joints are going to need to have lubricant. That's referred to as synovial fluid. It's a very oily, yellowy, straw-like colored that fills the entire joint space and basically serves as a lubricant to reduce friction. Braccia is another example where you can see where that fluid-filled sac or the synovial pocket exists. It also can cushion tendons in the bones to reduce friction, again allowing for that free movement that exists as part of that skeletal system. Here's an example of kind of what we're talking about here. Here's that bursa. You see where it kind of connects down through. Here's your example. This is your knee, your patella. This would be your humerus, and this is going to be or probably your humerus, not your humerus, your femur, duh. And then down here below would be your fibula. You can see that we have some meniscus here. It's one of the common things that get torn in a knee, especially if your knee gets hyperextended. You can see a ligament in the back and ligaments here in the front. Those are going to help, again, hold bone to bone. You're going to see that it forms this joint capsule. Now, if you look over here, you're going to see that joint capsule itself, and here's that fluid. It's not actually touching, but that fluid, that synovial fluid, provides that cushion that's there. The articular cartilage that's here as well, that's what provides padding. But because if you have problems with synovial fluid and it wears away or goes away, eventually you're going to be having the lack of cushion here, and it's going to wear away at this articular cartilage until the point where bone rubs on bone, and that's extremely painful for patients. Now, the muscular system, there are over 700 muscles in humans. Isn't that crazy? Allows for movement, supporting of soft tissues, maintaining our proper posture, body position, also protecting entrances and exits of our digestive and our urinary tracts, and then allows for us to maintain body temperature, all to maintain homeostasis. When we look at this, there is a ton of muscles. I'm not going to go through each one of them in this lesson, but take a look at figure 13.5. It's going to give you the breakdown of the more common large muscle groupings we would see. So when we're dealing with the patient who suffers from a non-traumatic musculoskeletal disorder or condition, we're going to know that they're going to present us most likely with pain and tenderness associated with some type of swelling or abnormality. Maybe based on a loss of movement or some affected joint. We may see deformity, either temporary or permanent, depending if it's a dislocation or if it's going to be more of a permanent related issue like a fracture or other long-term musculoskeletal disorders. And then we also know that our primary assessment is extremely important with anyone that's dealing with a musculoskeletal disorder, because muscles are also part of what help us be able to breathe. Our intercostal muscles and the ability for our diaphragm to contract. So ensuring adequacy of airway, breathing, and circulation, as in any patient, is extremely important. Now, your secondary assessment is really going to be focused more on the detailed history of the illness, right? We're going to review the patient's medications. We're going to do an exam focusing on joint pain, looking for tenderness or swelling or redness, range of motion problems. And then we're going to really pay close attention to what type of muscular disorders they might have, and things as far as range, restrictions in range of motion, points of tenderness or muscle spasms that could be existing. One of the common ones we see all the time is back pain. And if you haven't had back pain yet in EMS, you will at some point throughout your career. With back pain patients, we must do a detailed exam that includes conditions that require emergency treatment, such as caudal equina syndrome and other different components that we might see as far as neurological long-term problems. We also know that with back pain, neurological exams, including things like deep tendon reflexes or sensory or motor deficits, may also be helpful for us gathering a full picture of our patient. Last but not least, paying close attention to signs of urinary or fecal incontinence, as that can also times be associated with loss of muscle tone. Most of the treatments with back pain and any musculoskeletal disorder for that matter is really supportive and based on their symptomatic presentation. What symptoms do they present with? That's what we're going to treat. Typically, those include things like pain management, that we may use some type of opioids or analgesics to help relieve that. We may also consider NSAIDs, or non-steroidal anti-inflammatory drugs, things like your ibuprofen or your naproxen, different components of that nature. Last but not least is basic care. Never forget the basics, right? Splinting, minimize movement, minimizes pain, and consider the use of heat or cold packs. Now, one of the conditions that we see has to do with overuse or repetitive motion disorders. Not like any of us in EMS have ever had to use our backs to lift. In this case, it is a form of trauma, and it tends to be chronic. Often it's considered to be a medical condition because we've had chronic overuse of these muscles and bones. Again, it occurs from repetitive events, which leads to symptoms and signs similar to those associated with an acute trauma. Anywhere they're doing repetitive work, factory work, clerical work, EMS work, you name it, we fall into that realm. We also see common microscopic tears that are going to affect the tendons and muscles, because the muscles and tendons are going to break down with the use. But if we don't give them a chance to heal or for it to repair itself, those affected tissues are continued to be used and broken down. That's the big problem. We also know that these causes generally are going to be based on either trauma or maybe a crystal deposit within a joint, things like gout, friction, and then other systemic diseases like things like rheumatoid arthritis. Now, with these repetitive motion injuries, typically you'll see them presenting with pain or tenderness and range of motion issues that's going to be basically restricted because of either pain or swelling or both. Common things that you think of: tendinitis, bursitis, myalgia, carpal tunnel syndrome, just to name a few. Tendinitis is another one that we see, right? Tendinitis is inflammation of the tendon, oftentimes of the elbow and the bicep up into the shoulder. We may see tennis elbow. That's another common one you might see, where you get inflammation of the exterior tendon and the lateral aspect of the elbow. You may have golfer's elbow, which is going to be involving the tendinous sheath that inserts into the medial epicondyle. We also know that we can have a lot of other components that go along with this as well. Inflammation of the lining and the sheath that surrounds the tendon, bursitis. We could even have small synovial sacs along the tendons at points where friction can begin to develop. It's going to be very hard for us to determine what specifically we're dealing with, but we definitely know we can recognize the signs and symptoms associated with non-traumatic musculoskeletal conditions. Again, another one we might see is chronic malacia, where you're going to be doing painful condition of various causes. Could be caused by any number of things: improper lifting, moving, or turning. Any muscle that's overused or repetitively used, that's an example of what they're going to be primarily developing. Another one we might see is carpal tunnel syndrome, or CTS. This is caused by pressure on the medial nerve in the wrist, leads to tingling, numbness, and weakness, typically felt in the fingers and in the hand, based on repetitive motions, again, just like we talked about. So long-term chronic things can lead to the exacerbation of pain. Mostly you're going to see that a carpal tunnel as a work-related injury, especially as we text and type our lives away. Other degenerative conditions, we know that regular disturbances that can occur are going to have an impact on normal function, right? How well that tissue or organ will function. Now that deterioration or disturbance can be based on age or wear or tear. And again, you got to remember that these degenerative conditions can really affect any body system. It's part of the aging process, as we talked about in our geriatric lesson. One of the core things that we want to focus on when it comes to degenerative conditions, though, is osteoarthritis. Osteoarthritis is a degenerative joint disease where we see wear and tear on the joints. They just are taking a beating. Again, it's associated with aging, but it also has some genetic tendencies as well, because it does run in families. We also know that anything to do with your joints is going to be exacerbated by obesity. And the more you weigh, the more stress is put on your joints. And it can result from a number of medical disorders like hemophilia, avascular necrosis, or other arthritic disorders. Mostly with osteoarthritis, you're going to see pain and stiffness, right? Especially in the morning. You're trying to get out of bed, you're still sore, you can hardly move. It does become worse over time, but sometimes throughout the day or routine movement, once you get moving, it does get a little bit easier, but it never will go away completely. Things like routine movement and activities become painful, and it is a chronic condition. It can be improved as far as quality of life with medications and physical therapy, though. Here's an example of what you can see with osteoarthritis. Very hard for a patient to be able to use their hands, open medications, to be able to tie their shoes, to work zippers or buttons. Any basic function that you use your hands for really becomes a major barrier and hurdle to a patient with osteoarthritis. Now, that's osteoarthritis. If we switch gears to osteoporosis, now we're talking about, again, another common form of bone disease. But in this case, we're not talking about the joints, we're talking about the bone. So in this case, we're dealing with the thinning of the bone tissue or a loss of the bone density itself that can happen over a period of time. The body is going to fail to produce enough new bone to replace what's being broken down or reabsorbed or used. Calcium and phosphate substance are essential for normal bone formation. So if we find in a patient who suffers from phosphate substance, lack of phosphate or lack of calcium, they're typically going to be at an increased risk for osteoporosis. Now, the primary cause, believe it or not, in women is loss of estrogen, especially during menopause. This also is common in men, where we see a drop in testosterone levels. Now, there's an increased risk. Women over 50, you're in trouble. Men over 70, now you're in trouble. Again, we're talking about chronic problems. We're dealing with chronic arthritis, where these patients are going to be taking corticosteroids. They're going to be taking hypoparathyroidism drugs. They're going to be on a vitamin D supplement because of vitamin D deficiency. And oftentimes they can lead to bed rest or for them being bedridden because of their inability to get out without actually fracturing or damaging some of their bones. Now remember, this is a progressive disease. So the longer it goes, the more painful the bone will become, more tender it's going to be, and very commonly you'll see fracture with little to no trauma. That's a key indication of osteoporosis. Patient's going to lose body height because the vertebrae are collapsing upon themselves. They may also be prone to lower back and neck pain, and typically we see women who end up developing kyphosis of the spine, where we get that upper fat hump that we would see like the Hunchback of Notre Dame. We also know that with treatment-wise for osteoporosis, our care is going to be mostly supportive, making them comfortable. A lot of pillows can make a person with osteoporosis or osteoarthritis very comfortable. So pain control is something we may want to consider. Other therapies that can help bone loss and promote bone development. And then preventive strategies really to help reduce the likelihood of falls or any type of trauma occurring in the home. We know these folks are going to need to be on calcium supplement, probably some hormonal therapy, and believe it or not, exercise, because if we use our muscles, we use our bones, they regenerate more often. So exercise can oftentimes be used in conjunction with physical therapy. Another example of a non-traumatic musculoskeletal condition is degenerative disc disease. Degenerative disc disease is a common cause of low back pain. We oftentimes will associate it with, again, age-related changes. We know that as the body ages, discs have a tendency to become dehydrated, they become more stiff, they begin to function less effectively as shock absorbers, right? That's kind of what they do. They're there to help protect in between our vertebrae, that disc, and that can happen, especially over time. Outer layer cracks, again, it's a jelly-like material that's forced out through these cracks, causing the disc to actually bulge. So as it goes and those cracks develop, that padding, that buffer we have will seep out through, and it will cause the vertebrae to bulge. And you probably have heard that term as someone who has, I've got bulged discs, or had a ruptured disc. That's what we're referring to, is when those cracks are occurring inside that joint capsule. We know that herniated portions of the disc place pressure on the spinal nerves. We know that any type of damage to the spinal cord is bad, but we got to remember that vertebral column is designed to protect the spinal cord. It's when those herniated discs happen that it begins to put pressure on there, which can lead to more pain, especially with nerve pain, and then problems with weakness or muscle function. Remember that if that does not have blood supply, it's not going to be effective when it comes to repairing itself. And then also, remember, with degenerative disc disease, pain makes it worse. This is not a case to ask your patient to stand up and walk to the cot. Inflammatory conditions, again, there's a wider range of them. Primarily, we classify these based on joint disease or a group of rheumatoid arthritis or rheumatological conditions and dealing with inflammation in the joints. Anytime we're dealing with inflammation in a joint, it's going to lead to pain, stiffness, redness, warmth, swelling, all of the joint. We know that the inflammation can become so severe that the ability for them to move that joint can be lost. And so that's a concern. One of the big inflammatory conditions we deal with is RA, or rheumatoid arthritis. Again, a chronic disease that leads to the inflammation and injury to joints surrounding the tissue. It is an autoimmune disease. The body actually attacks itself, right? And it leads to the damage of these joints based on the autoimmune response. We know it's more common in women than it is in men, and it definitely has a major impact on joints of the wrist, fingers, knees, ankles, and feet. Again, those are going to be areas that we're dealing with normal daily functions of your hands and feet and mobility. We oftentimes will see fatigue, low-grade fever, malaise, and weakness. Again, that's associated primarily because of the autoimmune component. The joints themselves are painful and swollen, and they have a very hard time getting up and moving in the morning because of prolonged morning stiffness. Significant damage to the joints will occur with massive deformity. That's what makes RA so noticeable, is when you see the patient and their hands are just so crippled up. We'll see a picture here in just a second. We also know that this chronic condition cannot be cured. It can be managed, but there is no cure for RA at this time. Surgery oftentimes can restore damaged joints to a better function than they were, but it's never going to get us back to normal function like a healthy individual would have with healthy joints. A lot of the medications they're going to be on, believe it or not, are quite toxic. They're pretty heavy, hardcore drugs these patients are on, and oftentimes those are going to be used in conjunction with long-term physical therapy modalities as well. Alkalizing spondylitis is another one, or AS. This is an inflammatory arthritis, but now we're talking about it affecting the spine. So just think about that. Arthritis of the spine does not sound like a fun thing to have. We know that this is going to lead to inflammation of the joints between the vertebrae of the spine and the pelvis. And when that happens, that's going to lead to a lot of problems with inflexibility and being very stiff as it begins to kind of almost fuse together. Now, a fusion can actually affect the rib cage, restricting lung capacity. If the spine is becoming fused into a single unit, we know it's not going to be flexible. If it's not flexible, there's no extension, there's no lateral movement. It makes it very difficult for a patient to turn their head sideways, to bend over. And in essence, they no longer can move effectively as they once would. with their spine, and your spine really gives you a lot of flexibility. Now, a fused spine means it's extremely fragile because those discs, those vertebrae, which are supposed to allow for movement and flexation to allow for what we need to have happen, now becomes a solid fused component. Solid component means more likelihood for damage because now it just does not have that elasticity that it once had. So when you're dealing with patients who have alkalizing spondylitis, the biggest thing is to pad, right? The old stuff and fluff technique. Lots of pillows, lots of sheets, whatever you need to do to make that patient comfortable, because you got to remember, if they've got a permanent curvature of the spine and it's fused, you're not going to get them to lay flat or lay in any direction specifically other than the one that their spine is fused in. And you can cause a lot of pain and discomfort, even muscle spasms, to a patient who doesn't have the proper padding to make them comfortable during transport. The other part, if you think back to our airway lesson, one of the things we talked about during difficult airway management was the ability to align our planes or our axes, right? As far as the oral versus the laryngeal axis, the pharyngeal axis, so we can be able to see what we're dealing with. We know that aligning those axes can be very difficult with a patient who has a fused spine. Systemic lupus is another one that we deal with. This is a chronic autoimmune disease. Again, affects the skin, joints, kidneys, and a lot of other organs. It runs in families. It's more common in women. Reveals joint pain, swelling, and some will even develop full-blown arthritis because of it. Primarily, you're seeing fingers, wrists, and knees that are affected. We can see it present with chest pain, believe it or not, fatigue, fever, malaise, skin rash, swollen lymph nodes, any of the things, because again, it's a systemic autoimmune issue. The primary way that we deal with SLE is through a diagnostics of laboratory testing and a physical exam. There's not much that we can do for someone who has lupus. The big thing is going to be treat them based on their symptoms. Gout. Every time I think of gout, I always think of King of the Hill when Bobby ended up getting gout. Watch that episode if you have any free time. But gout is bad. Gout is basically where we're getting uric acid crystals that are going to be building up inside the joints. And every time you move your finger, those crystals are carving away all the tissue and structures of your joint. So again, it's another inflammatory arthritis, but it has to do with uric acid accumulating in the joints. The uric acid crystals in the joints is what gives us this what they refer to as gouty arthritis. It's like arthritis, but it's clearly gout. Not every patient will actually develop uric acid. Not every patient with uric acid, elevated uric acid levels, will actually develop gout. This is typically once crystals begin to form in the joint capsules, we then start to say, okay, now this is gout. And it tends to occur in families, right? Again, affects men more often than women. Now with gout, we're dealing with a lot of severe pain, swelling, and redness. I got a picture for this one as well too. The pain can actually be so severe that even sheets, just a light sheet or paper resting on a joint, can cause significant pain and inflammation as well, to the point where it's unbearable. So our treatment is really going to focus on treating the symptoms, primarily analgesia to treat and manage patients' pain and inflammation. We also know that dietary restrictions play a big role. If we can keep our uric acid levels low, we know we're less likely to develop uric acid crystals within our joints. Here's what those look like. These little guys right here, let me get my laser pointer. These little guys right here are what we're talking about. Nasty, nasty little bouts of crystallized uric acid that with any movements, those sharp, jagged crystals are going to rip and tear that joint component. So bad. Again, it's going to be something that in that case that may actually require surgery. Other infectious conditions that we could deal in regards to non-traumatic muscular conditions, these include things like soft tissue infections involving the skin or the tissue, the fascia, tendons, muscles. Cellulitis is a big one, right? Cellulitis is an infection of the skin associated with soft tissues. We see swelling, tenderness, edema, seepiness that's coming from our patients. Primary treatment for them, manage pain, treat the infection. Fasciitis is another one that we might see. It's an inflammation infection of the fascia. Remember, fascia is what actually creates these groups of muscles. It's what surrounds muscles, muscle groups, and blood vessels and nerves. It's a very fibrous type protective coating. If you've ever skinned a deer or even cooked ribs for that matter, oftentimes you're going to find that very fibrous, like they call it like silverback tissue or something like that, where you would take it off. That's the type of fascia that we're dealing with. Very tough, very fibrous, meant to protect. If we're dealing with fasciitis, this can be life-threatening, especially as it progresses. It can actually lead to I can never say this. We'll just call it necrotic fasciitis, where there's actually death to the tissue. In this case, it's actually a flesh-eating disease. Pretty bad. So fasciitis, if we're talking about that, bacterial infections rapidly destroy the skin, the muscle, the surrounding tissue, and again, it's most likely due to multiple bacteria. Causes widespread damage. Most likely the bacteria is going to be resistant, so they're going to have an antibacterial resistant infection. That's not good because there's not much that you can do to treat it. They become critically ill, and because of that, the mortality rate is very high when it comes to fasciitis. Gangrene is another component we deal with. Gangrene is basically because of death of the tissue that's occurred in part of the body that has an affected injury or had an infection or whatever it might have been that's leading to death to tissue. Blood supply is definitely going to be an issue because we know in order for tissue to begin, in essence, to rot and to decompose, it's going to have a blood supply that's going to be interrupted for a significant period of time. Things like peripheral vascular disease, diabetes, the immunosuppressed, or even following surgical procedures can lead to a problem with gangrene. Now with gangrene, we see it with pain and discoloration of the skin where it actually turns blue and then, believe it or not, black. If it's an internal infection, oftentimes you're going to see nasty green, black-like discharge, very foul odor, rotting, fleshy smell. They may not have a lot of sensation, but more of problems like pressure. I've seen this a couple times in my career, primarily associated with abdominal surgeries, where they leave a sponge or something inside and the patient calls because they get an onset of a fever and a lot of pressure. I actually had a patient one time who had a hysterectomy done and they left the sponges inside of her. They didn't actually account for all the sponges when they came out. And a lot of pain, a lot of pressure, had a really strong foul odor. And picked her up on a sheet, moved her to the cot. When we did that, her incisions split open and gangrene, black, slimy green fluid came out of her. And it was so disgusting. Words can't describe the odor. But that's one of those things that can happen when an infection begins to happen and the tissue begins to die. Here's another example that you might see. In this case, it could be an example of frostbite or a chemical exposure of some kind, and now that tissue is rotting and beginning to die. Another thing that we deal with soft tissue infections is the diabetic foot. We know that diabetes leads to a lot of nerve problems and sensation. Very easy for a diabetic patient to be walking and all of a sudden hit their toe on something but not feel it because of the loss of peripheral nerves, right? And so typically, again, that's because of poor compliance with their diabetes mellitus, and it has a lot to do with their peripheral blood vessels. If those peripheral blood vessels or nerves are damaged, they're going to have a decreased blood supply, decreased sensation, more likely that they're going to have an infection that can occur. So any type of laceration or skin ulcer leads to development of a serious foot infection, and we know it can spread to the bone and eventually causing osteomyelitis and potentially even having to have the patient's foot or leg amputated. It can be pretty serious when you're dealing with a diabetic foot. Another one we see is neuropathic I can never say this one either. This is another example of neuropathy associated with diabetes. Again, a complication of diabetes, we see it as a progressive degeneration of the weight-bearing joints, particularly in the foot. The bones become destroyed or deformed. It leads to ulcers, leads to problems, leads to infection, leads to potentially amputating the foot or leg or even death to the individual. Osteomyelitis is an infection of the bone. It can be acute or it can be chronic. It can be either one. It's just based on the duration of the infection. Again, a wide range of causes, both bacterial and fungal. And then the spread of the infection from the skin, muscles, and other tendons eventually can lead into problems with the bone. We see this with chronic wounds or those that have chronic skin ulcers. So your patients who are bed confined or nursing home who aren't properly rolled or maneuvered appropriately. We know that infections in another part of the body, again, that's going to spread from the to the bone via the bloodstream. That's what we're dealing with osteomyelitis. Those that are at risk, again, it's going to be your chronic folks. Those that have diabetes, chronic hemodialysis, intravenous drug users, peripheral vascular disease, recent trauma, or even having your spleen removed. Most of the signs and symptoms are going to be all over the board because they vary so much based on the patient's underlying conditions. Diagnostics are going to be done through imaging and laboratory analysis, not something that we're going to be able to do in the field. And the patient's going to need antibiotics and surgical drainage, and then potentially even resection of an affected bone area. Another one that we can deal with is septic arthritis, or referred to as a septic joint. These are infections of the joint themselves caused by bacteria, virus, or fungi. And we know that those that are at risk are those that were involved in surgical procedures. Maybe they have a prosthetic joint, or they're on immunosuppressive drugs. Another prime example in this case could be someone who has a knee replacement, very common, but if the bone were to become infected or the joint were to become infected, then you can see where you would end up having a septic joint. Infection can then spread from the joint to the direct contact with the skin, and then it gets into the bloodstream. At that point, now we're dealing with a septic patient. Now, neoplastic processes is another important. A neoplasm we know is an abnormal growth in the body in the form of some type of tumor, right? Tumors affect bones and muscle tissue, we know that. And primary musculoskeletal tumors arise from the muscle, bone, or other associated tissues, like ligaments and tendons. Secondary musculoskeletal trauma, or primary tumors, spread to muscle or bone from another site or another type of tissue. So we can either have it directly, or a primary musculoskeletal tumor, which starts initially in the muscle or the bone or somewhere nearby, or it's from a tumor that begins to spread into the musculoskeletal tissue, bones, things of that nature, from another type of tissue nearby. Now, the neoplastic processes is basically where you're getting the bone tumor is benign or malignant, right? So it's either fine or it's cancerous. Most benign bone tumors can happen. Those are referred to as osteochondromas. Most malignant bone tumors themselves are referred to as sarcomas, which is not too bad. Sarcomas arise from the bone, cartilage, muscle, fat, or any other similar tissue for that matter. Now, malignant bone tumors, there's a ton of them based on where they arise from. The cartilage, if it's Edwin sarcoma, which is going to be around the cell tumor, round cell tumor, osteosarcoma, again from the bone, or fibrosis sarcoma, which is going to arise from the fibrous tissue that supports things around joints and that. Now, malignant tumors can arise from the muscle and the connective tissue, right? So, rhabdomyosarcoma is another one we can see. We're getting arise from skeletal muscles. Synovial sarcoma comes from the synovium. Liposarcoma arrives from the fatty tissue. So again, it just can happen anywhere, but there's specific types based on the tissue in which it arises from. So pain, swelling, deformity are all going to be common complaints with these types of conditions, right? Fractures can also happen secondary to tumors because tumors can actually weaken the bones and joints around them. An acute onset of pain or instability in an affected part may be related to a deeper problem, more of a pathological fracture because of the underlying cancer. Treatment-wise, it's going to be based off symptomatic presentation of your patient. Remember, stuff and fluff technique goes a long ways with these folks. Chronic pain syndrome. Chronic pain syndrome is, in essence, pain that persists longer than others who have the same type of condition. So you've got an underlying condition, but the pain seems to stick around longer than normal. You might actually be diagnosed with chronic pain syndrome. It takes quite a bit to do that, and there are the 6 Ds that we deal with. We have dramatization of complaints. We typically see drug misuse, dysfunction or disuse, dependency, depression, and disability are all going to be issues that are associated with chronic pain syndrome. Chronic pain syndrome is defined as pain that lasts in excess of 3 to 6 months. It's associated with psychological syndromes, depression, anxiety, hypochondria, things of that nature. You're going to use a pain scoring system and long-term treatments, including things like medication and then the use of antidepressants as well. Fibromyalgia is one of the ones that fall underneath this. It is a central sensitivity syndrome. The thing about fibromyalgia is it really gets a bad name because patients will use that diagnosis oftentimes to seek medications. However, fibromyalgia is not a made-up fictitious disease. It is a serious disease. In essence, it is just pain in muscle or soft tissue from an unknown origin, where they don't really understand exactly why or how it develops. Cause is unknown. But we know that it's going to present with tender spots or trigger points that may oftentimes cause more severe pain to last for longer. It's often more common in younger or middle-aged women than it is in anywhere else. Now, fibromyalgia also leads to things like chronic fatigue, difficulty sleeping, headaches, difficulty concentrating, morning stiffness, irritable bowel syndrome, and even depression. So there's a lot that goes along with it. And folks, there is a lot that we still do not understand about the nervous system and our ability to sense and perceive pain. Another one that we would deal with is reflex sympathetic dystrophy. In this case, we're talking about chronic pain that basically is diffuse pain with swelling, causes limitations of movement that follow an injury to an extremity of arm or the leg. You're going to see pain and swelling. You may see some vasomotor dysfunction as well. And the type of complex regional pain syndrome is just going to depend. And so we classify it as a type of complex regional pain. Treatment, corticosteroids to help with inflammation, medication that may block the sympathetic nervous system, oftentimes may be used in some real severe cases. Surgical removements of part of the sympathetic nervous system actually can help, surprisingly, but it's one of those more severe, drastic type components. Another one that we typically would see would be juvenile rheumatoid arthritis with debilitating conditions of children, right? These include things where we may see Osgood-Schlatter disease, where we're going to have painful swelling of the anterior typical tibial tuberosity. Another one you might have is going to be basically on the growth plate, we're talking about. A bump on the upper tibia, below the knee, repetitive injuries before growth completes can cause problems with this as well. And typically, if you have damage, it's your RICE, right? Rest, ice, elevation, non-steroidal medication, things of that nature. We can also have a slipped capital femoral epiphysis, which is also we're going to get a separation of the ball of the hip from the joint of the femur. It happens again at the growth plate in the proximal femur. Very common in ages for boys at least 11 to 15, and they are growing, especially if they're obese or they're growing very rapidly. They've got a growth spurt. Diagnosed by an X-ray, treatment is going to be surgery to stabilize it. So in summary, I know we covered a lot of that relatively quickly, but the key things here are most musculoskeletal problems you will encounter as a paramedic are going to be traumatic in origin. That's going to be the basis. They've got a problem and they may have another underlying condition. Some of the non-traumatic conditions can be emergent, and they're characterized by acute exacerbations that may warrant pre-hospital care, especially if they're having chronic problems with an acute issue. Most emergency care is going to be is symptomatic, right? So based on the way the patient presents. And remember, the patient's primary complaint in this case is going to be pain, and treating it appropriately using medications that are recommended in regards to treatment. Measures such as rest, ice, compression, heat, elevation, typical first aid type treatments are going to be beneficial. In chronic pain conditions, there's often significant overlay of anxiety and depression and other components that are contributing to the pain as well. Remember that chronic pain in patients can be very difficult to deal with, and it's going to require a greater than expected dose of pain medication to relieve the pain. These guys are on a lot of pain medications typically because of their chronic illness, just to get through their life. What we have on our truck is typically going to be a little bit more serious or heavier hand of a dose to help actually manage their pain. Follow local protocols though. And remember, the role of the paramedic is to address the immediate problem, provide the needed transport, even if that's only symptomatic and supportive care. And so that concludes our lesson on the musculoskeletal diseases that exist and those that we may run across as pre-hospital providers. We'll catch you on the next lesson.